it's a small presentation. I'm just going to figure the clinical burden and try to talk about the gaps in the healthcare professional knowledge, and how can we manage the global objectives here in Portugal. So, as we all know, Aspergillus is a common fungus around all our nature, and the transmission is provoked by spores, and every day we are able to inhale almost 200 spores daily. There are a lot of species of it, but the main one is Aspergillus fumigatus, that is responsible for almost half of the invasive isolates. And of course, the clinical range goes from allergic one as ABPA to chronic pulmonary aspergillosis, and of course, the deadliest one, invasive one. But I find this article and it was quite worrying because the professional knowledge about fungi is a critical point. And in this study, only 13% of the healthcare workers had a good knowledge about Aspergillus, and 27% had a poor knowledge. And this aspect was quite worrying in the ICU staff, because where the patients are quite bad, the staff knowledge about this was poorer than that compared with the laboratory staff. So if we and if we know, so if the knowledge gaps can lead to failure to identify the symptoms, and also to the following safety protocols to these patients and exposing them to more risk of developing severe disease. Here in Portugal, the situation is not that good. So there is a lack of mandatory reporting. There is no national database about fungal infections. From all types of fungal infections. So this study estimated that every year there would be 1.6 million infections. And here in Portugal, we should look for our demographic risk patients with HIV and tuberculosis, because until 40 years ago, we had a high prevalence of tuberculosis. Now it's more controlled, of course, but in some of the patients, the pulmonary sequels of tuberculosis can promote and are a risk to these patients to have infectious disease by aspergillosis. In this study, they calculate that in the Portuguese population, that will be around 240 cases of invasive pulmonary aspergillosis, around 700 cases of chronic pulmonary aspergillosis. And if you look at the allergic forms, they estimated that almost in Portugal, that would be 12,000 people with ABPA and 6,000 people with severe asthma with sensibilization. Of course, these numbers are only estimations. We don't have any concrete data of the because we don't have a proper database with all these patients. Here in my hospital, we try to look at this in the pulmonology interventional department. We look during 1 year to all the bronchoscopies that we made here, and we found that in 72% in 72 cases there was fungal isolated. And when we look at the host profile in these 72 patients, only 34% of the patient were immunocompromised. So the majority of those were hemato-oncology patient, and 65% of the patient was non-classic hosts, so there were no immunocompromised. And I think this would be interesting to look at the patients with COPD and with asthma, with liver disease, that usually are not the classic patients that we look when we look for Aspergillus. Of course, the majority of patients was isolated and Aspergillus, and the fumigatus was the leading one, followed by the Aspergillus niger. And also we had 16 patients with Candida species, especially in immunocompromised patients. When we go look for the collection of Galactomana in the bronchoalveolar lavage, we saw that it was only requested in 1/3 of the patients, and because it's a retrospective study, it was difficult for us to decide why only in this third of the patients was collected, was made the Galactomana. In this period, I can say that there was a shortage in the laboratory equipment for doing it, so probably that is one of the reasons. And another data that worries us is the local sensitivity of Galactomana compared with the literature, and we talked to the laboratory staff, and actually they didn't give us a concrete answer to this. Probably a not good collection of the ball, or the good processing during the collection and until the ball reached the laboratory. Probably there was something in between that we cannot control it. And when we evaluate the percentage of these 72 patients in which a fungal agent, and we call fungal agent, was identified, only 18% of these patients receive treatment. And the conclusion that we reach is usually fungal identification is undervalued by the clinician. We had a high rate of interpretation as colonisation or co-infection by bacteria. So the majority of these patients didn't receive treatment. And I think this is very important because our patients are changing. We have more patients with COPD, with liver cirrhosis, so these patients live longer. A lot of patients are also admitted to the ICU during winter with COVID and influenza infections, and I think we should, in these patients, think about the co-infection with Aspergillus in this patient, and of course we need also to look about the resistance in the drugs that we use to treat these patients. I think that every doctor, nurse, whoever works in healthcare the clinical suspicion or suspicions of aspergillosis must be present, especially in every respiratory patient. When things doesn't go as well, we should look at a different agent, not just bacteria and viruses. And of course, it's really important to ask for a CT scan to look if there is a different aspect, especially the halo sign in Aspergillus. We should ask for a bronchofibroscopy, to ask for the bronchoalveolar lavage, to do galactomania, or even in the PCR techniques that help us to identify all these agents. And of course, we need to protect these patients. We need to protect them from the construction and renovation sites. We need to use fragile patients. We need to use rooms with positive pressure and HEPA filters to protect these patients from the spores, and of course remove all the plants and all the flowers that are near the patient. And of course, in a immunocompromised patient, also to control the water supply. It's very important to reduce the risk of these patients. And I think here in Portugal, it's very important to ensure that, of course, 90% of the population has access to diagnostic and to the treatments. This is quite difficult, I think, especially in Alentejo, because there are no pulmonology and infectiology departments with enough pulmonologists and enough infectiologists, and the access to healthcare is quite difficult sometimes to this patient. Even to go to the GP, sometimes it's quite difficult. And the population is quite old in those in that region. So, of course, it's another step that we need to take. The creation of a proper database and a proper reporting system, as we have from the other infectious disease, it's quite important. And it's of course, it's important to recall every doctor and to recall the doctors that there are Aspergillus infections, and that it's important to look for this for this. And of course, we need to increase the survival of invasive aspergillosis, especially in the ICU and in admitted patients. So it's very important to develop and validate new screening, new simple screening tools that allow us a good and confident diagnosis in the meanwhile, allowing that the patients are not put in the colonisation or a colonisation by Aspergillus, or it's just a bacteria, and we shouldn't treat the Aspergillus that we isolate in the bronchial lavage. So, in conclusion, here in Portugal, the fungal disease is quite serious. So it's important to create a mandatory database and epidemiological surveillance, maintaining all the patients with high index suspicion, and try to reduce the misdiagnosis, and of course allow professionals to have resources to just be updated with the latest information and all the tools that they need to give the best care and the best treatment to all the patients.